cellulitis and other bacterial skin infections. Key points. Cellulitis is a spreading infection of the skin extending to involve the subcutaneous tissues. Many conditions present similarly to cellulitis. Always consider differential diagnoses. The typical presenting features of all skin infections include soft tissue redness, warmth, and swelling, but other features are variable. Allergic reactions and contact dermatitis are frequently misdiagnosed as cellulitis. If there is itch and no tenderness, cellulitis is unlikely. Background. Cellulitis. The most common causes are group A Streptococcus, gas, and Staphylococcus aureus. Predisposing factors include skin abrasions, lacerations, burns, eczematous skin, chickenpox, etc. Although the portal of entry of organisms is often not seen. Impetigo, commonly called school sores. Highly contagious infection of the epidermis, particularly common in young children. Causative organisms are gas and S. aureus, may be associated with scabies. Staphylococcal scalded skin syndrome, blistering skin disorder induced by the exfoliative, epidermolytic, toxins of S. aureus, primarily affects neonates and young children. Necrotizing fasciitis. Cause, rapidly progressive soft tissue infection characterized by necrosis of subcutaneous tissue. Causative organisms include gas, S. aureus, anaerobes, and is often polymicrobial. It causes severe illness with a high mortality rate, 25%. Recent infection with varicella is a risk factor. Cellulitis associated with waterborne organisms. Aeromonas. Species, fresh or brackish water, and mud. Mycobacterium marinum. Fish tanks. Vibrio. Species, salt or brackish water. S. aureus, including MRSA. Gas, coral cuts. Infected animal/human bites. Caused by different organisms and often require different treatment. There are many other forms of skin infection that are not covered in this guideline. Assessment. Typical presentation of all skin infections. Soft tissue redness. Warmth and swelling. Pain/tenderness. Mild cellulitis. Features above. No systemic features. No significant comorbidities. Moderate cellulitis. Features above with moderate swelling and tenderness. Systemic features, e.g. fever, tachycardia. Severe cellulitis. Features above with severe swelling or tenderness. Large body surface area involved, e.g. larger than the patient's handprint. Mark systemic blank. Mark systemic features, e.g. fever or hypothermia, tachycardia, tachypnoea, altered conscious state, unwell appearance, hypotension. This is a late sign. C. Features suggestive of necrotizing fasciitis include severe pain out of keeping with apparent severity of infection, rapid progression, blank. Red flags. Abscess or suppuration. Animal or human bite. Deep structure involvement. Foreign body. Immunosuppression. Lymphangitis. MRSA in multiple comorbidities. Blank. Facial/hand involvement. Varicella associated infection. Differential diagnosis. Large local reactions to insect bites are a common mimic of cellulitis. Features include a punctum at the site, itch as a prominent feature, redness and induration, but rarely pain. Management. Investigations. Swab for gram stain, charcoal/gel/bacterial transport swab and slide, and culture if discharge present. Blood culture is not useful in mild/moderate cellulitis. Consider imaging, e.g. ultrasound, if abscess, deep infection, or foreign body suspected. Treatment. Manage. Blank. Blank. Manage source if identifiable, i.e. remove foreign body, drain abscess. For ongoing management, refer to flowchart below. Summary of antibiotic therapy. Blank. Cellulitis frequently looks worse after 24 hours. Cellulitis frequently looks worse after 24 hours of treatment. Consider waiting 48 hours to change therapies. Blank. Blank. Diagnosis: impetigo. Antibiotic. Topical mupirocin 2% ointment or cream to crusted areas TDS. Or cephalexin 33 mg per kilogram. Total duration: 5 days. Diagnosis: mild cellulitis. Cephalexin 33 mg per kilogram, max 500 mg, oral TDS. 5 days. Moderate cellulitis. A trial of high-dose oral antibiotics with close review may be considered. Cephalexin 33 mg per kilogram, max 1 g, oral TDS. Consider ambulatory/hospital in the home, HITH, if available. Ceftriaxone 50 mg per kilogram, max 2 g, 4 daily. Cefazolin 50 mg per kilogram, max 2 g, 4 bd. 5-10 days. If oral antibiotics not tolerated or no improvement after 48 hours. Severe cellulitis. Hours, manage as poor. Severe cellulitis. When improving, switch to oral antibiotics as per mild cellulitis. Severe cellulitis, or scalded skin syndrome. Flucloxacillin 50 mg per kilogram, max 2 g, 4-6H. If rapidly progressive, consider adding clindamycin 10 mg per kilogram, max 600 mg, 4-6H. 5-10 days. Consider early discharge to HITH once stable. Improving, antibiotics as per mild. Improving, switch to oral antibiotics as per mild. Cellulitis. Necrotizing. Fasciitis. Blank. Meropenem 20 mg per kilogram 4, max 1 g, 8H, N. Clindamycin 10 mg per kilogram, max 600 mg, 4-6H. Consider IVIG. Urgent referral to surgical team for debridement. Seek specialist advice for antibiotics. Consider IVIG. Mammalian bites. Uninfected, prophylactic. Often do need prophylactic need prophylactic antibiotics. When indicated asterisk. Amoxicillin/clavulanate. 80 mg/ml amoxicillin oral liquid, 7:1. 22.5 mg per kilogram, max 875 mg, oral BD. 5 days. Animal/human bites, infection. Amoxicillin/clavulanate. 80 mg/ml amoxicillin oral liquid, 7:1. 22.5 mg per kilogram, max 875 mg, oral BD. If unable to tolerate oral antibiotics. 25 mg per kilogram, max 1 g, 4-6-8H. 5 days, extensive, severe, penetrating, involving deep tissues. Seek specialist advice. Waterborne skin infections. Seawater or water. Cephalexin 33 mg per kilogram, max 1 g, oral TDS and ciprofloxacin 10 mg per kilogram, max 500 mg, oral BD. Or trimethoprim/sulfamethoxazole 8/40 mg per kilogram, max 320/1600 mg, oral BD. 5-10 days. Clean and debride wound. As needed. Prophylactic antibiotic not recommended. Asterisk indications for prophylactic antibiotics in animal/human bite. Presentation delayed by and GT 8 hours. Puncture wound unable to be adequately debrided. Bite on hands, feet, face. Involves deep tissues, e.g. bones, joints, tendons. Involves an open fracture. Immunocompromised patient. Cat bites. Suggested antibiotic therapy where MRSA is suspected. Blank. Diagnosis. Antibiotic. Total duration. Comments. Mild cellulitis. Trimethoprim/sulfamethoxazole 8/40 mg per kilogram, max 320/1600 mg, oral. BD. Or. Clindamycin 10 mg per kilogram, max 450 mg, oral QID. 5 days. Moderate cellulitis. A trial of oral antibiotics with close review may be considered. Or. Blank. When improving, to oral antibiotics as for mild cellulitis, severe cellulitis, or staphylococcal, scalded skin, syndrome. Blank. Or, clindamycin 10 mg per kilogram, max 600 mg, 4/6H. When improving, switch to oral antibiotics as for mild cellulitis. Risk factors for MRSA infection. Residence in an area with high prevalence of MRSA, e.g. Northern Territory, remote communities in northern Queensland. Previous colonization or infection with MRSA, particularly recent. Aboriginal and Torres Strait Islander or Pacific Islander child. Consider consultation with local pediatric team when no improvement or deterioration after 24-48 hours of therapy. Deep abscess or necrotizing fasciitis suspected. Consider surgical opinion. Consider transfer when child requires care above the level of comfort of local hospital. Consider discharge when able to tolerate oral antibiotics.